Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everyone, and welcome back to the podcast. My name's Chuck Dowell, doing a case of the week this week. So our case this week is a 15-year-old gentleman who I saw in clinic. He came in complaining of swelling within his knee. He and his father had stated that for the last 1 to 2 weeks, every time he would participate in lacrosse activities, he would notice some increased swelling throughout the knee with occasional pain within the knee. The swelling had gotten progressively worse over the last few weeks and now is getting some mechanical symptoms such as some catching and locking within the knee. The swelling would reduce if he took a day or two off of these activities, but then would reoccur right after participating in these sports activities. His father originally thought this was associated with IT band syndrome and therefore sent him for or started some physical therapy regarding this, and he was not noticing improvement of his symptoms. If you are following this along on the YouTube channel, I do have the images for this patient when I saw him in clinic, so definitely go check those out. I'll try to put all of the images on that as well. So again, when I saw him in clinic, his examination at that time was a fairly large palpable effusion noted within the knee. He had some diffuse tenderness noted throughout the patellofemoral area with a slightly positive allotment sign. His range of motion was slightly limited. He was able to obtain full extension, but due to the significance of the effusion within the knee, he could only flex his knee at about 60 to 80 degrees. He thought this was necessarily a locking, as he didn't want or started to contract when I started to flex his knee past this 80-degree point, but it did have a soft end point, so I think likely related to the effusion. The limited ligaments exam I could get due to the limited range of motion showed that he didn't have any varus or valgus instability at this kind of 10, 30, and then loosely 50, 60 degrees. His Lockman's test was negative at this time. Was not able to get him up into that kind of hyperflex position for those meniscal rotation type testing or posterior drawer testing, but again, he didn't have a necessary mechanism related to this. We discussed with him that because it had been going on 1 to 2 weeks, because of his age and the recurrent effusion or swelling he was having within his knee, I was very concerned that he possibly had some kind of cartilage defect within the knee. In my past experience, most of the time when young, healthy, athletic kids come in complaining of swelling within the knee and not associated with trauma, or sometimes associated with trauma such as patella dislocations, it's usually related to cartilage issues, whether they have a congenital cartilage issue or some progressive patellofemoral syndrome. Typically recurrent effusions, especially with higher level activities in young patients, are related to cartilage issues. So as you can see, if you're following along again on the YouTube, the x-rays, including AP weight-bearing films, show that he had open physis, but no acute fractures were seen. The lateral view also shows that he has some soft tissue edema with a joint effusion noted. A small flabellum is noted, but again, no cartilage and or fractures are seen. The sunrise view again shows joint effusion with some soft tissue edema diffusely out around the knee area. So again, because of the concern of possible cartilage injury, we ordered an MRI on him. So a few days later, he was able to obtain this MRI. Again, the MRI views could be seen on the YouTube channel and as the video associated with this. So looking through the MRI, this is our kind of axial cuts. Coming down, initially you can see there's a large loose body noted within that kind of suprapatellar recess area. So as discussed, he has a loose body, which is probably causing the varying of his symptoms, but does have a large joint effusion. So anytime you do see a loose body in the MRI, you want to find where the source, where the donor site for that loose body is. So if we keep scrolling through, kind of going down into the patellofemoral area, you can see his patellar articular cartilage looks quite well intact. He doesn't have a trauma related that would make us concerned for an MPFL type injury. His patella is sitting slightly laterally, but that's likely related to the joint effusion he has. If we keep scrolling through, we could see here's our donor site. So this lateral aspect of the trochlea shows a large articular cartilage defect noted. So in this patient, he had a osteochondral defect. And for this patient, because it wasn't associated with a trauma, we would call this osteochondritis dissecans. So for those of you that don't remember, osteochondritis dissecans is a pathologic lesion affecting the articular cartilage and typically the subchondral bone, and has variable clinical patterns. Most of the time, it's picked up on MRI, but occasionally can be seen on radiographs. A lot of the times, this is picked up as an incidental finding. A patient comes in and you see it within the normal and most common area, which is the medial femoral condyle. If it doesn't have a loose body, if the cartilage is intact and there's not a lot of subchondral edema, then we can typically treat these non-operatively with restricted weight-bearing activities, especially in patients with open physis where we don't want to have any effect and or cause any trauma to that physis with surgical intervention. In patients with closed physis and they do have a obvious defect and or there's a loose body, we can treat this surgically. This does typically occur in kids, usually between the ages of 10 to 15 years old, with the median age being 13. Again, 70% of lesions are typically seen within the medial femoral condyle, and often this will cause softening of the overlying articular cartilage. Often the articular cartilage is intact, and that's why frequently we can treat these non-operatively. So in this patient, unfortunately, you can see he did have the defect, and the defect did create a loose body. So we weren't able to treat this non-operatively, so we did take him to surgery. So the surgery photos, you can see here, there is a large articular cartilage defect noted. The donor site can be seen here within the trochlea, and you can see there's some kind of, scar tissue, within that area or fibrin tissue within that area. So this is more chronic in nature. A lot of the times when this is acute in nature, you'll see that this bed within the area of that donor site will have kind of bleeding subchondral bone. So that kind of indicates the chronicity of this. He may have had this loose body that was synovialized, and with his higher level activities, potentially, that's what created it to dysplays. So the surgeon went in, was able to measure the two loose bodies, and then was able to create a bleeding bed and fixate the loose body. So you can see the surgical photo here. They put 3 darts and or bioabsorbable screws in the area to hold down that articular cartilage defect. And oftentimes, if we have subchondral bone attached to that articular cartilage, these can heal quite well. So as a follow-up, this patient was doing quite well. He, at his 3-month appointment, had full range of motion, had discharged from physical therapy, and was able to start participating back into some low-impact exercise activities. Because the cartilage is involved, these often take a long time to heal, so these can be 4 to 6 months before they're able to fully participate all the way back into these exercise-related activities. We did end up getting an MRI on this patient because he came back in complaining of some increased pain. The MRI did show that the articular cartilage defect was stable and was doing quite well. Thank you for listening to this case of the week. I think this is a very interesting case regarding recurrent effusion in a young, healthy, athletic gentleman, which turned out to be osteochondritis dissecans. I hope you enjoyed this. We will try to do a couple more cases of the week with the x-rays and MRIs if available. So you guys that are following along on the YouTube channel can get both the visual evaluation of the x-rays as well as talking through the case. Thanks again for listening. Please go ahead and follow us on both our YouTube podcast, Ortho on the Go podcast. We're also on both Facebook and Instagram. Again, please feel free to leave comments regarding possible cases or discussions you would like to have reviewed. Again, thanks again for listening, and we'll talk to you soon.